You can start, sir.
Okay, sir. So just to introduce yourself, following Pfizer's long tradition of promoting science and providing a platform for interactive, insightful discussion, today we gathered here to listen, discuss, and learn about uh, urothelial carcinoma. So today we have the esteemed faculty with us, Dr. Nagendra Sharma, Principal Consultant at Max Saket Hospital, Dr. Piyush Bajpayee, HOD Medical Oncology at Manipal Hospital, Dr. Vikas Talreja, Senior Consultant at Kanpur, Dr. Abhishek Raj, Senior Consultant at Sarvodaya Hospital. So welcome to you all, sir, and over to you, Nagendra, sir.
Thank you. Thank you very much, Lav, for giving me the opportunity to be a part of this scientific session. So the title is very much clear, like optimizing treatment options in advanced urothelial carcinoma. So we all know that getting advanced cancer diagnosis, it's not only devastating for the patient, it's actually devastating for the entire family. The challenges which these patients face, they are not only physical, they are emotional, they are psychological, they are spiritual, and above all, they are financial. So if you ask me what are the highly lethal cancers or most lethal cancers in spite of standard oncological treatment, the list starts with metastatic carcinoma of pancreas, extensive stage small cell carcinoma of lung, and then third or fourth down the order, we deal with advanced urothelial carcinoma because there are so many negative trials which we have seen over past couple of decades. We are not able to increase the overall survival or progression-free survival. There were negative trial after negative trial after negative trial, so much so that advanced urothelial cancers used to be called as graveyard of phase 3 studies. But over a period of time, we have seen that we are having multiple agents which have come. And if I tell that we are dealing with we are going through a golden era of advanced urothelial cancers management or unresectable locally advanced urothelial cancer, I don't think it's an overstatement. So the purpose of today's meeting is that what is the correct treatment options for advanced urothelial carcinoma? Where are we in 2023? And slowly, one by one, we will dissect what are the treatment options and what is the thought process of a medical oncologist when we are dealing with these notorious cancers, because of which we have lost so many patients in past couple of decades. So, right. So this is my disclaimer. So the Bavencio, this is a new drug, it's a new drug in the block, and then right now we know that it's a human anti-PD-L1 immunotherapy. It's having adaptive and immunities. It's having a role in the immunotherapy management for advanced urothelial cancer. It engages both adaptive and innate immunity, by which we can increase the progression-free survival, overall survival, and we can add the quality of life with the limited lifespan which these patients have. So as far as avelumab, which is also known as Bavencio, there are three standard indications as far as oncology is concerned. First is first-line metastatic urothelial cancer maintenance or locally advanced unresectable urothelial cancer as a monotherapy for the first-line maintenance treatment of adult patients with locally advanced or metastatic urothelial carcinoma whose disease has not progressed with first-line platinum-based induction chemotherapy. Second indication is first-line advanced RCC in combination with exitrib is indicated for first-line treatment for adult patients with advanced RCC. Other indication is Bavencio is indicated as a monotherapy for patients for the treatment of adult patients with metastatic Merkel cell carcinoma. So these are the three FDA-approved indications. The focus of today's presentation or today's panel discussion is urothelial cancer in maintenance setting. Where are we as far as immunotherapy drugs are concerned? So first-line metastatic urothelial cancers or locally advanced unresectable cancer, this is the first and only immunotherapy to demonstrate overall survival in the first-line setting for locally advanced and metastatic urothelial carcinoma as a maintenance treatment. So this was an unmet need because for so many years, there was no maintenance therapy which was approved by FDA. So once we have given systemic treatment for 4 to 6 cycles and the patient have not yet progressed, neither patient have progressed, patient have achieved a partial response, stable disease. So we never used to have anything. We used to keep this patient on follow-up, 3 monthly once for first 2 years, then 6 monthly once for subsequent 3 years, and lifelong annually thereafter. But now we are having FDA approval in the first line maintenance. and we'll dig deeper on this molecule and what are the other options and how we are taking decisions in day-to-day practice. So, patient attrition between the first line therapy and later line therapy in real-world scenario in metastatic urothelial carcinoma, we all know we are having a multiple options. There are many trials which are done, first line, second line, third line. So I want to ask my esteemed panelist, may I ask Dr. Pierce, sir, what percentage of your patient receive a second line or subsequent lines therapy in your practice, in which first line you have given the platinum-based doublet? What is your practice, sir?
Yeah, Dr. Nagin, so this is actually what I see. There is probably a third of attrition in the subset of patients. So probably 2/3 would take the second line therapy. So there would be some attrition, of course, because of the sort of disease they might come up with on progressions.
Right. Aptly said, sir. So nearly 2/3 means by and large around 60 to 70% you are trying to
60 to 70% would be inducted into the second line.
Second line. And what about third line, sir, in your practice?
Very difficult to comment again. But these days now, one thing is it's actually quite variable. It depends also on the patient having a health cover. So, for example, if I have a patient who has a health cover, whether it's a government panel or whatever panel, or some health insurance, we can confidently ask the patient to do the scans timely. But it might not be the case otherwise.
Your voice is breaking, sir. There is a connectivity issue at your end, sir. Dr. Piyush? Yeah, now you are audible, sir, and visible also.
Yeah. So what I was trying to say is that it depends also on the health cover that the patient has. So sometimes, and also the motivation of the patient. So motivation of the patient and the support group. So both the factors are important. So as I said that for the second line, it's nearly 60 to 70%. Third line, very difficult to define. Also, third line is probably dependent on these two factors, what I stated. So if it's a motivated patient and the support system, as well as the insurance cover is there, then probably these patients who have this, amongst these, nearly 60 to 70% would be able to get the third line as well.
Okay, fair enough.
So the problem is that the third line therapies, once we are looking at, some of them are, most of them are not actually available with us. So there also lies the challenge that, getting the NGS done and asking for these therapies. So third line is a bit of challenging. So second line is yes, I would be able to induct, but third line is a challenge.
Fair enough, sir. You aptly summarized what I was trying to ask. So may I ask my other co-panelist, Dr. Abhishek Raj, what is your practice, sir? Like, how many patients will be fit enough for second line and how many will be third line or beyond?
I think of all the patients I do treat, suppose I'm treating 100 cases of urothelial cancer, metastatic urothelial cancer, I think 60% of those will end up receiving second line because of various factors. One is, of course, the motivation level of the patient, and some patients do have a rapid or fulminant disease course, and they can have a very early progression, and their performance status might deteriorate very fast before we can actually treat them. Yes, between second and third line, the gulf is even bigger. So probably I would be able to offer a third line treatment because of various reasons, because of the affordability issue, because of the social issues, or because of the disease factor per se. I think not more than 25% of my patient will be able to go to the third line.
Right.
And this is despite me treating a lot of government panel patients and all, where the availability of the drug is not an issue. So that's probably a disease, or probably the number of drugs that we have to treat urothelial cancer in such a scenario in a third line setting is like really challenging.
Absolutely right. So I think Dr. Vikas Taleja also joined with us. Dr. Vikas, are you there? So I don't think Dr. Vikas have yet joined. So I just want to know, sir, like if you are dealing with a good performance status patient who is young and fit, in your first line, what treatment choice of the drug you will be using? Whether you are going for AMVAC in any of these scenarios in your practice, or you will go for a platinum-based doublet in all the patients, irrespective whether the patient is fit or not. So I will start with Dr. Piyush, sir.
The MVAC is a sort of obsolete. Probably we have some discussion in tumor boards, more of it when it's a neoadjuvant situation, dose dense MVAC. But largely it is like cisplatin based gemcitabine and cisplatin or carboplatin based on the platinum eligibility. I'm getting a call from emergency, Dr. Nagendra. Can I take this? And I'll
no issues, sir. No issues.
Thank you.
May I ask this question to Dr. Abhishek? If you can come on screen, sir. So in your practice, sir, have you ever used MVAC, or what was your experience?
I have not.
You will choose.
I have not used MVAC in a first line metastatic setting yet. I've mostly been using gemcitabine cisplatin, and MVAC traditionally it has been there, but I am yet to use it in the first line. I have used in patients on second line after progression on gemcitabine cisplatin, and the patient is not affording for immunotherapy. I maybe give them a break, and if the patient progresses and he's still fit enough, so maybe I can use MVAC in a second line. So, but in the first line, I'm mostly using gemcitabine cisplatin or carboplatin based on platinum eligibility. If the patient is not even carboplatin also eligible, then maybe I can opt for a single agent immunotherapy or something like that.
Fair enough. So I just want to ask, like what you told is absolutely correct, sir. But two things I just want to ask: like the patients who are not fit enough for MVAC upfront, whether they will be fit enough in second line. That's a very, very important question. Second thing is, majority of patients performance status deteriorates, right?
The reason for choosing MVAC, because since I have not used it ever in the first line, and I have a limited experience even in the second line, the problem with MVAC traditionally, as my teachers used to tell me, that MVAC is a quite toxic regime as compared to gemcitabine cisplatin. So there is a lot of neutropenia, and febrile neutropenia rates are also there. So that's probably the reason that I find that, and something which you have used it in your practice, you tend to get more accustomed and more used to. You get that comfort level of using the same drug again and again. So that's the reason I choose gemcitabine and platinum based therapy upfront.
Fair enough, sir. Fair enough. So like in your practice, have you ever used immunotherapy plus chemotherapy upfront only in first line setting, or you are very selective that you will be using gemcitabine platinum based doublet where the patient is cisplatin eligible, carboplatin eligible, or platinum eligible? All those things are correct. But have you ever used immunotherapy plus doublet platinum?
I have used. I used to use your chemotherapy plus your atezolizumab, but with the data of Bavencio now available, and considering that now we have data for overall survival advantage benefit with avelumab, I'm usually now reserving immunotherapy as a maintenance therapy now. So I've stopped using it in the past 7-8 months.
Right. But so this is a very important point which you're doing.
In fact, I do have 2-3 patients who are doing very well, fantastically well on atezolizumab maintenance. They achieved a good partial response, and I still have 3 patients who are doing relatively well, and one of them is almost on atezolizumab for 20 months, and he is in CR. So despite whatever the results have come, but since bladder has also got a high tumor mutation burden, there is definitely a role of immunotherapy in bladder cancer, and we know that chemotherapy alone is not sufficient.
Fair enough. So Dr. Piyush sir, if at all you have to use immunotherapy in first line setting, are you doing PD-L1 upfront and then decide whether to use this, or you are using the same immunotherapy as a maintenance, or you will switch the maintenance even if you have used upfront immunotherapy, chemotherapy?
So for whatever reason, if in case I'm pushed against the wall to use immunotherapy upfront because of the patient not being, having the eligibility criteria, then yes, of course, after a PDL1, then irrespective of the PDL1, whatever it is. But otherwise, immunotherapy has largely been pushed to a second line setting, especially now with this maintenance data also coming in and showing overall survival. I think so the entire positioning of immunotherapy has been now in the second line setting, if at all. My experience with immunotherapy in first line setting along with chemotherapy has not been very exciting. So I have used it. I mean, PDL1 is what I have done. Of course, it is now essential to check upon PDL1 if you're positioning your immunotherapy in the first line setting. But that's what it is. Yeah.
Fair enough, sir. So I think Dr. Vikas Taleja also have joined now. So may I take this liberty to ask Dr. Vikas, how are you, sir? Right.
All well, sir.
All well. So this question is there in front of you, sir. Like, we are having three scenarios. One is platinum eligible or platinum ineligible. In platinum eligible, whether the patient is cisplatin eligible or cisplatin ineligible, right? So in your practice, sir, what percentage of the patients you see belong to each of these segment? And what factors do you consider while defining platinum ineligibility?
So most of my patients, I believe, are platinum eligible. So if I have to put to the numbers, I believe 90% of them are platinum eligible. Out of them, 70% are basically cisplatin eligible. And if we go by the textbook criteria of being cisplatin eligibility, so if I do a pure tone audiometry, I do a DTPA scan, I do the ototoxicity assessment, neuropathy assessment, and also the whole geriatric assessment of them, I believe then the ratio of that cisplatin eligibility becomes 30%. But if I go by a clinical routine criteria as for a judgmental value, I believe 70% I try to give it, because we know at the back of our mind that cisplatin and carboplatin aren't the same molecules. So the response rate is definitely with cisplatin is much more higher, and survivors are slightly skewed towards the cisplatin. But I always tend to put the platinums, even if I can't put a cisplatin, I tend to make it cisplatin eligible, because of if there's suppose nodes compressing on ureter causing increased hydroureteronephrosis, and with BJ stenting and probably first dose of carboplatin, those nodes shrink and they become cisplatin eligible down the lane. That's also I try to do it. And I always believe in the switch maintenance theory also as compared to a continuous maintenance. So first is the chemos, because they have a very good response rate, and what they do is they prime your tumors to the immunos which you are using as a maintenance. So 4 cycles chemo followed by switch maintenance to Bavencio is what I usually practice. Too much cooks spoil a broth. That's what the concept is, and that's why I am not a fond of chemo plus IO combination upfront, because if it fails, we don't know what to do next, and most of the time we don't know what worked also. So it's always best that you bioselect your patients as those who have 4 cycles chemo, reduce the burden of disease, and then put as something as maintenance as IO.
Fair enough. Absolutely summarized, sir. I do agree with whatever you have told. So only point here is like, what factors do you consider while defining platinum ineligibility? What are your factors? Like, these are the things, if it is there, I will not use platinum.
So again, that becomes those 10-20% are those who are probably not fit for any form of therapies, because they are probably poor performance status. They are those patients where because of their age or because of the comorbidities which are uncontrolled, I believe it would be too hindrance to give chemotherapies. So most of them are those patients whom I would be chemo ineligible patients as compared to just platinum eligible, because whenever I plan chemotherapy, I believe platinum is an essential component for the therapies. So I tend to give it either the cisplatin or carboplatin, but being a platinum ineligible is, I believe, 10% to 15%. And there I only think of probably, even if I have to give some form of therapy, I would give a single agent gemcitabine or a paclitaxel single monotherapies rather than the doublets. So if I have to consider doublets, platinum is essential.
Fair enough. So I asked this question to Dr. Abhishek and Dr. Piyush also, like what are the right fit patient for MVAC upfront in first line setting? So I was not able to take inputs from you, Dr. Vikas. So what are the right fit patients in which you will use MVAC? What is your experience with this drug combination?
So MVAC is definitely a very old regimen and that has stood its test of time. But with the practice we usually have, I know, I believe.
Dr. Piyush want to say something?
No,
Yes,
no,
sir.
no.
Okay,
Let Dr. Vikas complete it.
right. I think,
Okay.
yeah.
If
yeah,
in case
please.
it's his video is stuck.
It's frozen, I think.
Sorry.
Now he's there, right.
So,
Dr. Vikas, you're there?
yes.
Okay.
With neoadjuvant adjuvant intent, I would prefer dose-based MVAC regimen. With palliative intent, I believe gemcitabine cisplatin does majority of the work
Fair enough.
as compared to the dose
Fair enough.
and MVAC regimen.
Right, sir. Dr. Piyush, you want to comment?
नहीं, मैं ये कह रहा था कि मुझसे विकास से या अभिषेक से पूछने की जगह जो है तुमको डॉक्टर श्याम अग्रवाल को पैनल में बुलाना पड़ेगा.
Right. But you are most experienced among all of us, sir. You are having
मैं
a lot
बता
of
रहा हूँ
experience.
dose this MVAC जो है.
Right.
By the time we were actually into practice, MVAC would have actually taken a back seat.
Correct. Right. So coming to the topic, sir, next is like the platinum-based chemotherapy eligibility. We are the things which we are. There are 5 basic criteria by which we will tell that this patient is platinum eligible. You know that one is the performance status. The patient is having a performance status of 3, beyond 3, that means 3, 4, or critical illness of less than 30 ml per minute. When a patient is having a peripheral sensitive neuropathy of greater than 3 grade, NYHA heart failure of class greater than 3, and the other thing which all know that if the patient is having a performance status of 2, but pattern clearance of less than 30 ml per minute. So point here is, do you routinely check audiometry, sir, in your practice, or are you doing nerve conduction velocity to find out if the patient is having uncontrolled diabetes, or if they are having more like prone for peripheral neuropathy? Are you doing NCV study or audiometry routinely in your practice while deciding eligibility for platinum? Dr. Piyush, you can take this.
So not audiometry, yes. Audiometry is definitely yes, because there is some, and deafness could be actually a very incapacitating thing and could lead to high and poor geriatric, risk scores could increase from that perspective. Yes, so I do audiometry, but no NCV. I mean, most of the time it's a more of a examination in terms of, checking physically, clinically. So yes, audiometry.
So my point here is, I was asking a very pointed question, like if the patient is telling that I'm not having any hearing loss, clinically he's not having hearing loss.
So most of the times we see the epidemiologically these are cancers for 6th or 7th decade. So therefore, and then these patients have diabetes, comorbidities as well. So yes, most of the times I do check for audiometry, especially I'm actually offering them cisplatinum, then yes, I do that.
And the audiometry shows that patient is having a mild sensory hearing loss, or conductive and mild both are
So
there.
I do go ahead with
mild?
that. I do go ahead with giving platinum agent, and this is the main purposes in a fitter patient to actually follow up how the patient, have a If there is tinnitus happening, then repeat audiometry. And if there is a decrement, significant decrement, then of course. So the baseline is basically the baseline, and the latter part, the repeated this thing all helps in deciding how to go further in therapy.
Right, fair enough, sir. Just want to ask, like, if the patient who's not complaining and you have done audiometry and it has shown, suppose moderate sensory hearing loss, whether you will not give platinum in that age, then echo is okay, performance status is 1, heart ejection fraction, everything is okay, or creatinine clearance is 90. So what is the factor, whether it's an absolute contraindication or relative contraindication? This is what I want
It's
to
a relative
begin.
contraindication, of course. That's what I said, that moderates, I mean, platinum, cisplatin is important. And I would want to deliver cisplatin, especially in a neoadjuvant setting. In metastatic setting, or probably in a moderate sensory neural loss and the patient complaining, I would shy away from giving cisplatin. I would rather go for a carboplatin because I have seen falls increasing. If in case the patient is having no symptoms, not even tinnitus or, but just the audiometry showing, then I would rather have a, subjective repeat of the test regularly and also monitor the patient closely. I would want to give cisplatin because it's an important drug.
Absolutely right, sir. Absolutely right. So, Dr. Abhishek, what is your take, sir? So, do you routinely check audiometry whether patient is having clinical symptoms or not? What is your take in your practice?
Yes, I'm doing audiometry regularly in all my patients. The reason being that, as Dr. Piyush said, that deafness is a really big problem for the patient, and it has medical legal implications as well. So audiometry for every patient I'm doing, yes. And for mild sensory loss, if it is got a mild sensory neural hearing loss, probably I will still use cisplatin with a careful monitoring of the symptom, or maybe repeat audiometry after maybe 2 cycles to see if there is further fall in the decibel levels, and then maybe decide whether to continue cisplatin or not. NCV generally, severe sensory motor neuropathy, if the patient is having, it will be manifested clinically. So yeah, clinical examination is just what I'm doing.
Fair enough. So I was I'm trying to ask, this is a very, very important point which I'm discussing, because majority of us are doing audiometry. I do agree. But the point is, are we taking decision based on that report? Pointer is, you told me clearly that if it is mild sensory neural loss, hearing loss is there, which is instantly picked up, I will go ahead with platinum because the benefit is more, right? Second thing is, if the patient is having moderate, whether we will go for platinum again? Answer is yes. You told that yes, moderate or mild, I will not change my decision. I will just monitor audiometry closely, correct? So only absolute contraindication is when you are having a grade 3 or severe sensory hearing loss, then only you are going to not to deliver platinum. Is this the consensus here, or anybody is having a different take? Dr. Vikas, also you can take this question. Very, very important point. Dr. Vikas?
So I always have that concept of you look at the hearing level decibel loss, and especially important is if it's 4,000 decibels, I believe cisplatin is a strict no-no, because once that ototoxicity hits, it is an irreversible concept. So you can't reverse it back with whatever agents you try to do it. And that's why it is very important that you check with every cycle, or probably with every 2 cycles, the audiometry decline of the patient. And also tend to see, because even though cisplatin has its response rate, it has its fair share of toxicities, the whole point of continuum of care gets disturbed if the patient has a fall and becomes a bedridden during any course of the time. So important that.
Fair enough, sir. I got your point, what you are trying to convey, but I was just my pointed question is, suppose I will make it more difficult. Suppose the patient is having a moderate sensory hearing loss, grade 2 peripheral neuropathy, and patient is having a creatinine clearance of 55. Whether you will give platinum or not. My pointed question is this. I require a pointed answer. Dr. Vikas, you can take this.
Absolutely no. So because there are multiple factors which are borderline, so would prefer to give a carboplatin and switch over to IO in metastatic situation. If
Fair
it's a new adjuvant situation, then definitely cisplatin, yes. And monitor very closely before giving cisplatin at every cycle.
Okay. Dr. Piyush, sir, you can take this like creatine clearance of 55 with a grade 2 peripheral sensory neuropathy, and patient is having a moderate sensory hearing loss on audiometry. Whether you will
Because
give
you gave
platinum or not.
50 and now you have increased by 5 ml more. So, okay. So, Dr. Nagin, this is actually very, it's very difficult to say like one particular scenario. But of course, if in case the patient, we want to deliver cisplatin, but as Vikas and you are trying to say that if there are other concerns, then probably cisplatin can take a backseat, as in peripheral neuropathy you pointed out is also there, diabetes is also there. Probably then you can bring carboplatin straight away. So it is like, it's just not the hearing loss which would alone be there. Yeah,
absolutely right. So we have to see the absolute contraindication and relative and permutation combination of this. Then on that clinical scenario, we have to take a call. Isolated one sensory hearing loss of mild or moderate will not change your platinum decision. You will go for cisplatin, right? So and we have to just monitor that closely. And if it is deteriorating, if a mild or moderate sensory hearing loss is coming as severe hearing loss after 1 or 2 cycles, obviously we have to switch it over to carboplatin. That is what I think we are having consensus here, right? So what is the overall survival benefit that you usually observe with chemotherapy in your practice? Dr. Abhishek, you can take this. What is your overall survival which you have in your practice? By and large, if you're using...
I think in a routine practice, we are seeing an overall survival of around 1 year. Because I think avelumab has just come into picture. We are not quite experienced with that. But if we see the overall picture and considering the kind of patients we see with poor performance status, anywhere between 10 to 12 months.
10 to 12 months. Fair enough. Dr. Piyush, sir, just a
I
ballpark
agree.
figure I want.
Agree.
You agree? 10 to 12 months by and large.
Yeah.
Dr. Vikas, your practice is it same only on your city or you're having a better overall survival? Hello, Dr. Vikas.
I'm sorry, I was...
Please unmute. I request all my co-panelists, please unmute yourself so that we can discuss, right?
So the question is, what is the OS that you observe with the chemotherapy in your practice? That's the question, or
the question is like when you use the standard drugs like gemcitabine and cisplatin in your practice, what is the median overall survival by and large?
Less than a year. That's it. That's
less
the
than
maximum,
a year.
I believe.
Fair enough. So all of us are having consensus. The majority of patients will not be able to cross 1 year if you're using even the best drugs like gemcitabine and cisplatin, right? That's why this is one of the lethal cancer. Okay, so that's unmet need. For over 20 years, the platinum-containing chemotherapy has been the standard of care because of its high initial response rate, but it has limitation. So even though 75% to 80% of the patients achieve a disease control with first-line platinum-based chemotherapy, just 25 to 50% of the patients do not receive second line. This is what already we have discussed. 64% of the patients progress within 9 months. Remember that. And 12 to 15 months is majority times is the survival, which is poor with all the standard drugs, no matter what we do upfront. So where are we now? This is the unmet need, and we have to change it by correct sequencing, right? So if an unresectable locally advanced or metastatic urothelial cancer, which is your preferred approach as a platinum eligibility, whether you will go for cisplatin or carboplatin, that we have already discussed that wherever possible, we'll try to give cisplatin, right? Now the point here is you have given first-line chemotherapy, patient have tolerated very well, and patient have got a partial response or a stable disease. One approach is that we can wait and watch, and whenever the patient progresses, we will start second-line treatment at the time of progression. Second approach is we can continue maintenance. Suppose we are given chemo immunotherapy upfront, as Dr. Abhishek was mentioning that I've used atezolizumab plus chemotherapy doublet, and patient have achieved CR, partial response or stable disease, stop chemotherapy and continue the same IO maintenance which you started upfront. And then when the patient progresses, in spite of IO maintenance, then from the progressive side, take a biopsy and then go ahead with the second line therapy. Fair enough? Other approach is switch maintenance. Suppose we have given gemcitabine, cisplatin, or gemcitabine carboplatin for that matter, and patient have achieved a CR, PR or stable disease.
I'm sorry.
he's
sir.
there. Please
Sorry.
unmute yourself, sir. Right.
I'm audible?
Yeah, you are audible, clearly audible.
Perfect. So, gemcitabine cisplatin followed by IO maintenance. That's the switch maintenance, continuous maintenance, or I would say that's usually what I prefer. First line, I don't prefer the immunos, so it's only the chemos followed by the immunos maintenance is usually routine practice what I do.
Okay, fair enough. Dr. Piyush sir, are you having the same practice or which of
Yeah,
these
I would desire a switch maintenance, but I end up doing wait and watch.
this is financial or the performance status?
Yeah,
deviation?
most of them, yeah, because of course, yes.
Okay, logistic issues
Of course,
are the
yes.
main
Logistics are the main hindrance.
Fair enough. Dr. Abhishek, your input, sir. Have you changed your practice from wait and watch? Or you are still...
I think I just told that initially we were doing some chemo and IO in some cases, but yes, now I've changed my practice. I'm using chemotherapy, gemcitabine, cisplatin, carboplatin, 4 cycles followed by switch maintenance. I also see a lot of cash or TPA patients, and they're often difficult for them to afford because of the financial issues and all. So in such patient, if I have to convince them for IO maintenance, if the patient has achieved CR or near CR or they're PD-L1 positive, there probably I try to convince them more because there the data is the strongest in the Javelin 100 trial. But apart from that, mostly, as Dr. Piyush said, that in most cash and TPA patient, I end up observing those patients.
Okay, only 2 pointed questions to Dr. Abhishek. Dr. Abhishek, I just want to know, as you brought PD-L1 higher, then only I will offer. So first of all, are you doing PD-L1 for all your patients? Point number 1. Secondly,
Yes.
are you recommending NGS? Because right now we are having a targeted drug also, although availability is an issue, but are you doing that in affordable patients, NGS upfront?
Okay. So yes, I am doing PD-L1 for all my bladder patients, even though the trial says that you can do it for, because it makes me easier to convince the patient for the therapy that, okay, the data is pretty strong if patients are PD-L1 positive. NGS, yes, I am doing after patient progresses after first line of therapy.
Okay. Dr. Vikas, are you up for NGS upfront or at the time of progression? Or are you doing PD-L1 for all your patients before taking a decision of avelumab maintenance? Dr. Vikas? You can take Dr. Piyush, sir, if he's not there.
Yeah.
Question is like, are you doing NGS upfront or at the time of progression from the progressive side? It is accessible. Or you are doing PD-L1 for all the patients, or you are selective in your approach?
Most of the time it's on progression that I do NGS. It's on progression of the first line that I would consider a NGS. PD-L1, as I stated, that if in case I have rather stopped doing a PD-L1, I have probably more of an insight into how the therapy would do, especially the pembrolizumab or the Atizo. From that perspective, yes, I would do that, but it's dwindling for me. Yeah.
Right. What I wanted to ask is why I was framing this question is, suppose you have done NGS upfront and you have got a FGFR mutation or any other mutation for that matter, whether you will be skeptical in switching over to avelumab, because we know that if you are having a targeted mutation, majority times in no matter whatever cancer you are having, you will not go for immunotherapy, right? Because they are not going to work. The point here is, suppose I have done NGS, I have not done something wrong, but I picked up incidentally a mutation, whether in that case also you will use wait and watch approach or you will still use avelumab.
I think so. The FGFR patients were also there in this particular trial. So I'm not sure about the subset analysis over here, but yes, if in case it's on the table, then it becomes a real point of discussion, what to be used. For now, I would use avelumab.
No, why I'm framing is, like, suppose you have not recommended in any of your patient NGS upfront, which is correct, there's nothing wrong in that, but patient have come to you after third cycle for that matter, and NGS done by some doctor elsewhere, NGS report is there with him, he's having a targetable mutation. Now you have completed 6 cycles at your center. Now the question is standing in front of you is that I have to use avelumab maintenance, whether you will be up for it in a targetable, actionable mutation, which is there, because we know that immunotherapy will not work.
I think so. The hypothesis of targeted therapy working better would always be there, but I am not sure about this question, Dr. Nagin. So
fair enough.
Rather,
no, sir, this is a gray zone. I do understand. Just I'm framing. These are the real clinical scenarios. That's why here are gray zones. This is a correct platform to discuss. So, Dr. Abhishek. So my point, same question to you, sir. Suppose a patient have come to you from elsewhere, and the patient the doctor there have advised NGS, patient was affordable, and they have come with the report to you, and they have already completed 3 cycles, and patient is a good performance status. You have completed 6 cycles of gemcitabine cisplatin, but the NGS report is showing a targetable mutation, whether you will go for avelumab maintenance in spite of that.
I think I will go for avelumab maintenance. I think in the Javelin bladder trial, I don't think they have done a subgroup analysis based on FGFR report. I'm not yet sure. So, but this is what the guidelines say. I don't think any guidelines recommend that if FGFR mutation is there, you should not use this drug. I would go for this.
Right. Fair enough, sir. Not an issue. This is what I want to take a call. So upfront NGS, that's why it will not carry any clinical significance as of if all of us are having consensus. We should not recommend upfront NGS in metastatic urothelial cancers. And we should not recommend PD-L1 also for that matter, because irrespective of PD-L1 patient have got benefit. So what's the point in doing that? All the patients we should give avelumab if they have not progressed after 4 to 6 cycles of platinum-based doublet. Is this the consensus? Or if you are having any different uptake, you can correct me. I think all of us are having consensus here, right? Fair enough. So we'll move to this point now. Wait and watch approach. Why this is immaterial right now? Because we are not doing that by and large, because we are having a drug which have shown an overall survival benefit and a PFS and quality of life also. So first line platinum-based chemotherapy, the objective response rate is 40 to 50%. Disease control rate is 50 to 80%, but median overall survival hovers around 15 months. No change. So 50 to 80% of the patients achieve a disease control with first-line platinum-based chemotherapy. However, overall survival is limited by chemotherapy resistance. And the median overall survival in cisplatin-eligible chemotherapy is not beyond 15 months. And for carboplatin also, it is slightly less, 1 to 2 months less, like 13 to 14 months. This is median overall survival of the standard drugs which we used to do in our practice. So is there any role of IO therapy in first line? Why I'm asking this is, suppose somebody have done PD-L1 and it's 100%. So whether you'll be like tempted to use IO chemotherapy in first line setting if PD-L1 is 100%, may I ask this to Dr. Vikas? Dr. Vikas, can you unmute yourself?
Yeah, sorry.
PD-L1 100%.
I don't.
First line maintenance, first line chemotherapy regimens, whether you will use chemo only, doublets, or chemo IO.
Till I have a substantial data for it, I would not use. I would reserve my guns for the switch maintenance, because Eventually has shown it for a good that there is data for the overall survival for maintenance. So till the time I have a first line data for a PD-L1 strong positive to take into account that yes, this drug works in the first line as a PD-L1 positive population with the OS benefit, I wouldn't change my routine practice.
Okay, so you'll stick to the chemotherapy doublet, platinum, including platinum, and then you'll reserve available maintenance, whatever the PD-L1 is, right? Fair enough. So continuation of maintenance approach. So none of the IO chemotherapy or IO studies provide a median overall survival benefit in these difficult to treat populations. So we know that we are having IMvigor 130 trial, we are having Keynote 361 and Danube trial, right? Danube is a famous river in Europe, right? So treatment strategy of chemoimmunotherapy or IO doublet is with Danube. We know that. So experimental agents are atezolizumab plus platinum-based chemotherapy. For Keynote 361, it is pembrolizumab plus platinum-based chemotherapy. And for Danube, it is durvalumab plus tremelimumab. So the status of the IMvigor 130, which is atezolizumab trial, it is awaiting the final results. And there is no significant difference in overall survival at the second interim analysis of AACR 2021. Keynote 361, it's also a negative trial, did not met overall survival and PFS primary endpoint as depicted in ESMO 2020. Danube, which is IO doublet, in which durvalumab and tremelimumab is used, that also is a negative trial, did not met overall survival endpoints as published in ESMO 2020. So this is the reason why chemoimmunotherapy upfront is not the standard of care. We are not having consensus here, which is the right fit for this. That's why no matter whatever the PD-L1 is, we should reserve the IO drugs as a maintenance, right? So platinum-based chemotherapy plus anti-PD-1 or PD-L1 leads to non-significant improvement in the overall survival in intention to treat population. IMvigor 130, that is atezolizumab trial with platinum doublet. The median overall survival is 16 months as compared to the placebo or the competitor arm. Hazard ratio is 0.83. As you can see, the Kaplan-Meier curves, they are more or less not amazing results, I should say. Keynote 361, already it is a negative trial. Hazard ratio is 0.86 and 12 months overall survival is 61.8 and in the placebo arm it is 56%. So not a major difference. As you can see, they are majority times they are overlapping or marginal difference, you can say. The platinum-based chemotherapy plus anti-PD-1 or PD-L1 leads to minor improvement in the survival as far as progression-free survival is concerned. The median PFS of ITT in PFS is 8.2 and the comparator arm is 6.3. Hazard ratio, not very amazing, 0.82. We know that lesser the hazard ratio, better is the experimental arm. Keynote 361, PFS intention to treat population is hazard ratio 0.78. All the benefit is there, but it is not much significant as far because it's a negative trial. Danube trial, which is a new trial in which IO was used in urothelial cancers. There's no indication of that till now, till this trial was published. So durvalumab and tremelimumab is tried, and the co-primary endpoint was overall survival, and selective secondary endpoints were overall survival and PFS, objective response rate, and duration of response. The data cutoff was 27th of January 2020, and median follow-up was 34 months, and median follow-up for survival was 41.2 months. What was this trial showing? It was showing a median survival of 13.2 months, objective response rates of 26%, and median duration of response was 9.3% as compared to the chemotherapy arm. And it's not, that's why it's a negative trial. Next slide. That's switch maintenance, the Javelin Bladder 100. Now, this trial is the first trial which have demonstrated a significant benefit as far as median overall survival is concerned, as far as switch maintenance of IU. So, Javelin Bladder trial is a phase 3 study in which chemotherapy followed which IO switch maintenance was used, and the drug was avelumab, that is Bavencio. Median survival, there was significant benefit. I'll be coming to that. And there's one more trial which was tried in the maintenance setting, that is GU 14.182. It's a phase 2 study. I just want to mention here. Javelin 100, Bladder 100 was a phase 3, and pembrolizumab was used in this GU 14-182 trial. There's no significant benefit versus no maintenance. So only trial which is having a significant benefit as far as oral survival benefit is concerned is Javelin Bladder 100. That is phase 3 randomized controlled trial of switch maintenance of avelumab. So in unresectable locally advanced or metastatic urothelial cancer, platinum eligible, we are having a best option is when we use gemcitabine and cisplatin. All of us are having consensus here. So only approach that has translated into maximizing median overall survival is the third one, that is switch maintenance, when the patient have not yet progressed on the gemcitabine platinum-based doublet. They may have received CR, PR, or stable disease, but if the patient is not at progress, so irrespective of PD-L1, you can use avelumab if affordability and accessibility is not an issue. To summarize, what I want to convey is in metastatic urothelial cancers, who are randomized after CR, PR, or stable disease following platinum-based chemotherapy. So IO drug, the best drug is avelumab. If the patient is platinum eligible or ineligible, other trials are all negative. Deneuve also is negative. Pembrolizumab 361 also is negative. Vigor 130 also have not shown much benefit. That's why only viable option, as you can see clearly, is avelumab maintenance, switch maintenance, I should say. So maintenance therapy introduces a treatment approach for patients who have response or stable disease after first-line platinum-based chemotherapy. And this is what the maximum benefit we can achieve. We can increase the longevity of life. The first-line maintenance of Vivasio, avelumab, offers an alternative options to the wait and watch approach in patients who are progression-free after first-line platinum-based chemotherapy. So I think this message is very much clear. And maintenance therapy introduces a treatment approach that aims to prolong clinical response and maintain the patient's quality of life. It prolongs the response, it maintains the quality of life, and most important thing, works with the previous treatment. So preliminary data showed that IO therapy has a mechanism of action that complements the mechanism of action of chemotherapy, and in addition to IO maintenance therapy, may reinforce and sustain the clinical benefit of chemotherapy. Right? It prolongs. There is a decreased toxicities, and responses are much better if you are using. That's the main aim of maintenance therapy, especially switch maintenance. So overall efficacy and safety data of Javelin Bladder 100 trial, we already know that it's a phase 3 randomized open label parallel arm, 370 locations, 700 patients were enrolled, locally advanced and metastatic urothelial cancer. So remember that it is not for adjuvant treatment, it is for locally advanced and metastatic urothelial cancers who have not progressed on platinum-based doublet. Avelumab plus Besabodicare versus Besabodicare as a first-line maintenance treatment after first-line platinum-based chemotherapy. This is what this trial is by and large. So what are the inclusion criteria of this trial? Unresectable, locally advanced or metastatic urothelial cancers with measurable stage 4 disease who have received first-line chemotherapy, 4 to 6 cycles of gemcitabine, cisplatin, or gemcitabine, carboplatin for that matter, after a treatment-free interval of 4 to 10 weeks, in which radiological assessment is done of the response. And if the patient have not yet progressed or patient have achieved CR, PR, or stable disease, and especially in the PD-L1 percentage was 51%, so more than half of the patients were PD-L1 positive. Avelumab was used at a dose of 10 mg per kg body weight, IV, 2 weekly, plus Besabodicare. It is 1:1 randomization until how long it is continued? Till progression or unacceptable toxicity or the withdrawal. The primary endpoint of this trial, as we all know, it's a median overall survival. So in metastatic setting, there are very few handfuls of trials in which median overall survival is the primary endpoint. So you remember the metastatic pancreatic cancer for POLO trial, for those patients who are having platinum, like you have used the drugs upfront, 4 cycles, FOLFIRINOX, and the patient have not yet progressed. The median primary endpoint of the trial was PFS, the olaparib, right? POLO trial for pancreas. But in this trial, as you can see clearly, it's also a lethal cancer, and the primary endpoint is oral survival. So we always chase oral survival. Ultimately, we want our patients to live longer, right? The primary analysis population, all randomized patient, PD-L1 positive. Secondary endpoint was PFS, objective response rate, time to response, response duration, disease control, safety and tolerability, and patient-related outcomes. All were taken into consideration. And we all know the scientific rationale. So chemotherapy, we know it decreases the tumor burden, it decreases the immunosuppressive cells. So there is a PD-L1 upregulation when it acts on tumor, and because of which tumor neoantigens are increased. Antigen presentation is more CD8, T cell infiltration is there. But when we are using avelumab, so it acts on the PD-L1 receptors, and there is activation of the prime T cell and reversion of execution. There is induction of the innate effector function, deepening of the tumor response, ultimately leads to tumor cell death. That's the rationale of using avelumab post platinum-based chemotherapy in the patients who have not yet progressed. So baseline characteristic of this trial, the median age was 68 years. Majority of patients were males, 3/4 and 1/4 were female. Majority of patients were in excellent performance status, either 0 or 1. Location of metastasis, non-visceral was in 45% and visceral mets was 55%. And first line chemotherapy regimen, 52% have received gemcitabine cisplatin, 42% of the patients received gemcitabine and carboplatin, and 6% of the patients have received either of them, right? So unprecedented overall survival benefit in overall population. As you can see, the median overall survival was 21.4 months at 21.4 months, as you can see clearly. And hazard ratio also is 0.69, right? It is statistically significant and clinically meaningful also, as far as primary analysis is concerned. And the 7.1 months improvement in the medial survival in patient receiving Vivencio plus Best-Supportive versus Best-Supportive alone. The primary endpoint, when it was like 4th of June 2021, what they have observed is that the hazard ratio was 0.76, and there is a delta advantage of 8.8 months improvement in median overall survival in patients receiving Vivencio plus Best-Supportive versus Best-Supportive. So unprecedented oral survival benefit of PD-L1 patient, positive patient also have shown that those patients who are PD-L1 positive, they have done better when they have been exposed to this drug. So we know that from experience from other cancers also. As you can see, the forest plot, all the dots are on the right side of line of unity, favoring the experimental arm, that is Vivencio plus Best-Supportive care, no matter whatever the age, performance status, sex, or ethnicity of the patients. Majority of patients have done well. So there is a 1.7 months improvement in median PFS receiving Vivencio plus Best-Supportive care, hazard ratio 0.62 in the primary analysis, in which the cutoff was 2019, 21st of October, and long-term analysis came into 2021, June 4th, and there is a 3.4 months improvement in PFS also when we are using Vivencio plus Best-Supportive care versus Best-Supportive care alone. Hazard ratio was 0.54, which is much more amazing, because we know that less of the hazard ratio, better is the experimental arm. So would you like to perform PD-L1 testing? So all of you have agreed that PD-L1 is not that much necessary. Majority of patients, they will get response no matter whatever the PD-L1 is. So as far as the trial setting is concerned, NCCN recommends this, ESMO recommends this, EAU also recommend this. So available maintenance is recommended in all the platinum eligible patients, irrespective of PD-L1 status. So my question to Dr. Abhishek is, suppose the patient is platinum ineligible and you are not able to find out the cause by which you can correct the hydronephrosis or PCN and all those things, but you have given single agent gemcitabine or single agent paclitaxel for that patient. Now patient have not progressed stable after non-platinum containing first-line drugs, whether you will offer avelumab in maintenance setting. PD-L1 is 100%. Dr. Abhishek. Oh, Dr. Abhishek is not there, I guess. So Dr. Piyush, can you take this question, sir?
Yeah, I think so. I would offer avelumab if in case the disease remains stable or is in PR after the single agent. I would rather consider a gemcitabine and a paclitaxel combination most of the times where patients are platinum ineligible. There is some data to that combination. So I would use that irrespective of what the PD-L1 would be. So PD-L1 100%, so probably more convinced to use it. But yes, I would consider using a maintenance therapy.
Right. Fair enough. But in this trial, sir, as you see, and just now I have alluded to, that majority of patients were either carboplatin or cisplatin was given upfront. Yeah. But in a scenario in which you are not able to use because of the merit of the patient, you cannot use platinum drugs. So yes, you are up for avelumab maintenance in that scenario also, right? If I've heard you correctly.
No, so the whole concept probably is that there is a neoantigenemia after chemotherapy exposure, and that probably has led to whatever we are seeing. So irrespective of the platinum exposure, the platinum would give a more significant hit. But if in case you have the disease in control, probably it's a PR or a SD, it would make sense to actually use the needful drug, avelumab over there. It would make a case over there, because the whole concept is actually derived that if the disease is stable, the biology is such that there is some immune component to it, and you would want to use maintenance over there.
Right, fair enough, sir. Your point is well taken. Dr. Vikas, are you having any different thoughts? Yes. Like those patients who are platinum ineligible, we are not able to use platinum in the upfront setting. What is your take as far as maintenance is concerned?
I would say that it should be offered to everybody and irrespective of PD-L1 testing, because the data shows that across all guidelines and across all trials, it wasn't used as a stratified factor for distinguish between what to choose. And I really look forward to a very promising data also that also is coming from the pembrolizumab and enfortumab. So again, we have a very good second line agent that doesn't distinguish and has a different set of mechanism of action as compared to Evolumab. So I also want to give the best guns effort. So chemo, IO failure, Infotumab is what I usually practice. And I believe with that, right now, this sequence will give us a maximum best possible OS. So that's the way I look forward to it.
Fair enough, sir. Your point well taken. Suppose a similar scenario, I will put it. I'm just putting the real world scenarios which all of us are facing so that we can have a consensus here. Suppose a patient was treated elsewhere and come to a center in which atezolizumab plus platinum-based doublet is used. After 2 cycles of this chemotherapy in first-line setting, patient had developed grade 2 autoimmune side effects because of which you are not able to continue atezolizumab and you continued with gemcitabine and platinum, whether this is platinum or carboplatin for that matter. Patient completed 6 cycles and patient have not progressed after that. Whether in this type of scenario in which patient have received atezolizumab, whether you will use available maintenance or you will re-challenge atezolizumab maintenance only because you have used 2 cycles of atezolizumab. I think my question is clear, right?
I totally agree. Probably, I would say that if we go by the strict book criteria for Avelumab maintenance, the trial excluded all those patients who had received IOs in the previous 6 months of the therapy. So again, that would not be a textbook definition of Avelumab. However, given in real world scenario, he has responded to the chemo IO combination. So considering all scenarios, putting up front, I would say that I would definitely like to re-challenge because we know whatever we do, chemos won't give us more than a year for the patient and we need to do something more than that. So my preference would be to give some sort of maintenance. Probably it is that maintenance would be something I would. Switching between 2 IOs, I am not usually a fan of.
Fair enough.
I would
So we are having experienced oncologist, Dr. Rupesh is most experienced among all of us. Sir, a scenario, just I'm having a scenario like this in my hospital that a patient got treated outside and the doctor have started atezolizumab plus platinum-based doublet. Patient have taken 2 cycles, then came to my center. And the 3rd cycle also I used atezolizumab and platinum-based doublet. Patient developed grade 3 autoimmune side effects, autoimmune pneumonitis, right? I stopped atezolizumab, managed with steroids, and completed 6 cycles of gemcitabine-based platinum doublet. Patient completed 6 cycles without any issues. And after that, patient have not progressed. It's a stable disease. The question standing in front of me is whether I should switch to Avelumab maintenance in this type of scenario, or should I continue atezolizumab? It was a grade 3, suppose. So what is your take?
No, so your question is 2 points. So number one, in a pneumonitis patient which has resolved, a pneumonitis which has resolved well, should I give immunotherapy back again? One part is this. So there was in this, I attended the year-end review, so Vikas was also there. So there was this one paper someone had presented, probably Dr. Rajat from Delhi had presented, and this was on re-exposure of immunotherapy in patient who had immunotherapy-induced pneumonitis. And there it was like if the pneumonitis was settling to less than grade 2, rather, I mean, it's grade 1 and lesser than that. With the improved pulmonary function test, there have been re-challenges of immunotherapy happening, and patients are getting the survival benefit. This was also there for immunotherapy. This was there for radiation-induced pneumonitis also. So this was one interesting data. And regarding your choice of drug, I mean, I would want to go ahead with the maintenance therapy of Avelumab.
Okay, so post atezolizumab, when patient have got grade 3, which got managed by tapering dose of steroids, you will not use atezolizumab re-challenge as well as maintenance is concerned. You will switch and you will use Avelumab based on the data.
Yes,
right?
yes.
So that's correct. But the point is, like Dr. Vikas was adding, that in this trial, none of the patients who have exposed to immunotherapy, they were taken, right? Only those patients who are being exposed to platinum-based doublet without immunotherapy was the criteria. But real world scenario, if this type of picture is there, what is correct and what is wrong, and we always are in double mind, right? if this sort of scenario comes, so what should I use? It is also maintenance, is also correct. Or should I switch over to avelumab or not to give anything? There are the three options. But your choice is avelumab, right, sir?
Yeah, I would go for avelumab.
Fair enough. I think Dr. Abhishek also is there. I am not able to see him. Dr. Abhishek, are you there? I don't think Dr. Abhishek is there. Anyway, we will move forward as far as this presentation is concerned, because this interesting discussion is going on. Because all these are real world scenarios which all of us have to face and sitting on one side of the table, right? So would your treatment approach be different if the patient have achieved either CR, PR, or stable disease? I think all of us are having consensus that if the patient has not yet progressed, majority of times we'll go ahead with avelumab maintenance, irrespective whether patient have been exposed to platinum, irrespective whether patient is having PD-L1, irrespective patient have received immunotherapy partially or not, right? So I think this is correct that we have to switch over to avelumab maintenance. So in this trial, complete response.
You will get to see more of such scenarios, Dr. Nagendra. Now that practice of checkmate 274 would also come. So where adjuvant nivolumab is being used, in patients who have been node positive, something like what you used in cross trial setting. So
checkmate
577,
right?
Yeah. So where post neoadjuvant you have a residue on surgery, and you use nivolumab for a year, where the PFS benefit was realized to be almost doubling, nearly 22 months versus 7-8 months. So I think so that in this scenario we would see such patients which would eventually fail at some point of time and get chemotherapy back again, and have this re-exposure of avelumab.
Fair enough, sir. Your point is absolutely right. These are all scenarios which all of us have to face, and we should have our consensus there, what is correct. Otherwise, all of the time we are having a guilt inside that whether I'm doing correct or not, right? So this is the correct platform to discuss all these scenarios. So moving forward, Javelin bladder trial is an interesting trial which have shown a complete response. So those patients who have achieved a complete, partial, or stable response, these patients have done well. Those patients have complete response is there. The PFS was 9.5 months. Those patients with partial response, it is 3.8 months. And those patients who have got a stable disease, the median PFS was 5.6. And as far as overall survival is concerned, the avelumab plus best result comes if you have achieved a complete response, 39.8 months, which was never seen in any of the prior trials, right? Partial response, 19.2 months. So if you have got a complete response, you can see nearly doubling. You can see this has never been seen. The partial response, it is 19.2 months, median overall survival. But if you have got a complete response, it is 39.8 months. And look at hazard ratio, 0.72, 0.70, and 0.84. In stable also, these patients have done 22.3 months as far as median overall survival is concerned. One may argue that if it is stable response, they have done better than the partial response, right? Okay. So can we consider avelumab irrespective of chemotherapy with the Gemcis Gem-Carbo is offered in first line? So answer is yes. This is in the inclusion criteria. So whether you have, no matter whether you have used cisplatin or carboplatin upfront, you can still use avelumab. I think there is no doubt. So one more thing I just want to highlight here, right? If you have used carboplatin and cisplatin, what is the difference? The overall survival and PFS benefit with avelumab first line maintenance occurred irrespective of first line chemotherapy regimen. So doesn't matter whatever you have given, although the median overall survival is slightly better for those patients who have been exposed to cisplatin plus gemcitabine, but carboplatin also have done nearly well, nearly 20 months of median survival is there. But if you use cisplatin upfront, it is crossing 25 months or crossing 2 years for that matter, as far as overall survival is concerned. Look into the PFS. The PFS, median PFS is 4.6 months when we have used avelumab plus best supportive care in Gemcis treated patients who have not progressed. Hazard ratio 0.63. Median PFS of avelumab plus best supportive care is 3 months as compared to best supportive alone, that is 1.9 months, and hazard ratio 0.59 in Gem-Carbo treated who have not yet progressed. So how many cycles of chemotherapy do you usually recommend in your practice, sir? So may I ask this to Dr. Vikas, whether you are going for 4 cycles or 6 cycles, or same like for extensive stage small cell carcinoma lung, we are having debate whether 4 is sufficient or 6 if the patient is doing well. Dr. Vikas, are you there, sir?
I'm sorry. 4.
How many cycles you are usually recommending? 4 or 6?
4. So
4.
with that 2, I believe there's not much incremental benefit. That's whatever the responses we usually achieve by 4, toxicity's chances are much more. So 4 is something which I find equivalent, non-inferior, and ready switch to immunomaintenance as soon as possible.
So we will not go for 6 if the patient is tolerating very well without any chemotoxicity. Young fit patients, whether you are they are inclined towards 6 cycles,
Individualized
6 cycles and
decision.
start.
I would say that, let's say that would be an individualized decision. So
Okay.
I tell that 4 is what is minimum. 6 is something which is I would say maximum, and between 4 to 6, it is all individual based decisions as how much deeper the response is, how much fit the patient is, how much the things are right now. And since
Got
we
your
know
point,
what
sir.
we have to
Absolutely
do for
right.
the
So Dr. Piyush sir,
then-
what are your selective patients in which you will go for 6 cycles, GEM-CIS or GEM-CARBO for that matter, then switch maintenance to avelumab?
It becomes very difficult actually to deliver 6 cycles of cisplatin, GEM-CISPLATIN in the age profile that we are talking. I mean, of course, there would be a patient younger and fitter, so that might be the case, as Vikas said, individualized. But most of the times it becomes very tough to actually deliver beyond 4, whereas 4 is some number which has been there with bladder cancer. So I think so. Switch over to maintenance therapy if the data is there. So I think so. Once if the PR is established or is stable disease is established, CR is hardly that we see in less than 10%. So any of the 2 established, I think so. Switching over would be fair enough.
So first response assessment on chemotherapy, like at what cycle you will do, after 3, after 4, or if
Yeah,
the
I
patient is
will
already
do
after
after.
6 directly?
I'll do after 4.
After 4, right. I think Dr. Vikas also will agree after 4 only, and then we'll add 2 if the patient is young, fit, no chemotoxicities, no comorbidities, and GFR of 100, right? So these are the patients who are right fit for 6, if at all, have to be given. Otherwise, 4 is also better, right? Before switching to maintenance. Fair enough, sir. So overall survival is not affected by the number of cycles. This is what is coming out from this trial, and there is evidence for that, as you can see clearly. Suppose we are given 6 cycles, so median survival is how much? 24 months. That is 2 years. And suppose we are given 4 cycles, the median survival is 19.9 months. And if 5 cycles is given, 19.9 months again. So they are telling that if possible, try to give 6 wherever possible. Otherwise, 4 also, you are nearly reaching 20 months, right? So how soon you will start your avelumab post chemotherapy? Like within 3 to 4 weeks, 4 to 6? Because in this trial, they have used 4 to 10 weeks. So in your practice, whether you are doing the response assessment after 4 weeks post last chemotherapy tablet, or 6 weeks or 10 weeks, or immediately less than 4 weeks, what is your take, sir? Dr. Piyush, sir.
Yeah, most of the time it's usually after 3 weeks of the last therapy that we advise, 3 to 4 weeks after last therapy. That's what the PET CT time is, where the PET CT would or the CT scan would be positioned. I say PET CT, but then in bladder again, CT scan would suffice. So having said that, so somewhere between 4 to 6 weeks or 4 to 8 weeks is where I would offer avelumab. 10 weeks would be a bit too late, but there have been patients as per the trial. So somewhere between the 4 to 8 weeks.
Fair enough, sir. So minimum 4 weeks and maximum 10 weeks. We can take it like this. So anywhere in between, we are okay with that, right? There is no consensus, because as a trial, there are patients who have after 4 cycles, they have 4 weeks treatment-free interval, they have done the scan, and there are patients because of some issues, logistic issue or whatever it is, because of the infection which they have got. So few patients after around 10 weeks also they have taken. Fair enough. That's okay. The Javelin bladder trial, so maintenance like 4 to 6 weeks or 6 to 8, what is the difference? By and large, all these patients have got a better response. The prolonged overall survival and PFS were observed with avelumab plus bezaboticab versus bezaboticab alone in all treatment-free subgroups. So we should not break our hand in how many weeks interval we should do it, but minimum 4, maximum 10. This is what we have to remember. So this is the first line maintenance trial of 100 subgroup analysis. We all know in Asian subgroup also, if you look carefully, they also use 4 to 6 cycles, and around 4 to 10 weeks post last cycle, they have given this drug. And same trial was checked as far as Asians are concerned and what they have got, I will just quickly take you through. Median survival is 28.7 months as far as Asians are concerned, right? Hazard ratio is 0.78. And the comparator arm, that is best-body-care alone, it is 18.2 months. So nearly 10 months leverage when we are using avelumab in Asian patients. This is one point which I want to highlight as clearly depicted in this Kaplan-Meier curve. What about median PFS? Median PFS was 5.6 months as compared to 1.9 months only in best-body-care alone and Asian as a group. Hazard ratio is 0.58. So you can see clearly these patients have got a PFS and overall survival benefit much better than any other ethnic group. And immune-related side effects like 31.9% of patients, some or other adverse events which we all know can happen, but they're all manageable majority of times. So Bavencio is first-line maintenance treatment is a new standard of care in Asian patients with advanced urothelial cancers whose disease have not progressed with platinum-based chemotherapy. The primary endpoint median was always 28.7 months from the start of maintenance therapy versus 18.2 months with best vertical along among all Asian patients. 22% reduction in the risk of death versus best supportive care alone among all Asian patients, hazard ratio 0.78. Bavencio as a first-line maintenance treatment led to a numerically longer time to end of next line therapy in Asian subgroup compared to best supportive care alone. As far as safety and tolerability concerned, the safety profile of Bavencio first-line maintenance treatment in Asian patients was consistent with all the overall population. So treatment-related adverse events led to discontinuation of avelumab in 11.9% of patients. Death was attributed by the investigator to study the treatment authority in 2 patients, that is 0.6, not much. 1 death occurred due to sepsis after 11 infusion of Bavencio and other due to ischemic stroke 100 days after single dose of Bavencio. So this is rarely any stroke also happened, but very, very rare. So no grade 4, grade 5 adverse events were noted, and high dose corticosteroid, that is greater than or equal to 40 milligram total daily prednisolone or equivalent, were administered following immune-related adverse events in 9%. That means out of 10, 1 patient only required this at the time of data cutoff. So majority of side effects, which you all know, it is hypothyroidism, rash, hypothyroidism, pruritus, pneumonitis, colitis, all those things we all know with immunotherapy drugs. So 0.8% had a treatment-related adverse event after 12 months or beyond of treatment with Bavencio versus best supportive care. And would you like to continue avelumab maintenance? Like 47% of patients exposed to Bavencio greater than 6 months. Patient exposed to Bavencio 12 months is 28%, and patient who are exposed to Bavencio greater than 24 months, that is 2 years, is 20%. So median duration of treatment is 25.3 weeks. This is what I want to continue. Overall survival in patients with greater than 12 months of avelumab, as you can see clearly, it is much, much better. And how would you sequence the therapy in second line, subsequent lines? So suppose patient have progressed. Now, what will be your second line of agent? Dr. Piyush, you can take this, sir. Suppose you are given a platinum doublet, avelumab maintenance, patient have progressed.
Yeah, I think so. Like if the duration is more than a year, I would want to bring in chemotherapy back again. Of course, this is the time of doing NGS testing, as we discussed earlier. And then I have actually given a couple of patients Infotomab. I gave in the 4th line. I gave Trodelvy in the 3rd line. So sacituzumab is what I gave in a non-FGFR setting. In a FGFR setting, I gave lenvatinib actually in one patient. And one peculiar mutation came as a exon 19 mutation in bladder cancer. So I do not know whether it was an artifact or a pre-analytical issue or a real thing. But the patient actually did quite stable on osimertinib for almost 5-6 months. So yeah, I mean, NGS is the point over here that NGS should be done. And if the patient can go for, ADCs, then yes, ADC should be considered over here.
Absolutely right, sir. So Dr. Vikas, what is your take, sir? As sir have clearly told that this is the way out. What is your take? Are you doing a provisional site biopsy if it is accessible and then send for NGS and they take call accordingly, or you will switch over to chemotherapy or again, you will re-challenge with IO? Dr. Vikas, please unmute yourself. I don't think Dr. Vikas is there. Right. Fair enough. No issues. you will continue second-line treatment based on your NGS report. And many times decision is taken on individual basis, depending on the affordability and the performance status and how is the exposure to the first line was. So by and large, we are having consensus here that majority of patients, this is the way out. This is the way we use first line, second line treatments. The median survival is similar in all the subgroups of patients with or without second line treatment. By and large, we'll take decision based on this. So post checkpoint inhibitor, now NCCN guidelines in 2022 have chosen that we can use paclitaxel, gemcitabine, docetaxel, depending on your prior chemo tolerance. So what we are using in first line or maintenance setting will throw light that what you can do later on.
True.
So tissue is always an issue. If tissues are accessible, and then you can search for the mutations which are alluded to, and we can take a call based on that particular scenario. So we know that majority of patients, other options are available, and most important part of this presentation is this. So survival goes further when we are using the right IO at right time. This is what we have to remember. So if you use chemotherapy tablet upfront, majority times 3 to 5 months it will take. Treatment for interval of 4 to 10 weeks before first response assessment. If the patient are not yet progressed, you can go ahead with avelumab, no matter whether you are used platinum upfront, whatever the PD-L1 is. Median survival is 30 months, right? This is never ever seen. So 2.5 years patient can live if you use avelumab or Bavencio as well as first line switch maintenance is concerned. Suppose we have done a different scenario and we used immune checkpoint inhibitor in second line, even then the median overall survival will not go beyond 1.5 years. So immune checkpoint inhibitor in first line treatment, if you used atezolizumab plus chemotherapy, majority times the median survival is again 16 to 17 months, not even 1.5 years. And if you have used first line monotherapy immunotherapy agents like atezolizumab or pembrolizumab, it is 12.3 to 18.5 months. And if you have used durvalumab combination, in spite of that double IO combination, the median survival is just 15.1 months. So as you can see clearly, avelumab is having a leverage monopoly in maintenance. I think there is no doubt as far as data is concerned. It's a PFS advantage, OS advantage, quality of life, everything is there. So by and large, what I want to convey through this presentation is that long-term follow-up from Javelin Bladder 100 trial, within 2 years in all patients, continue to show prolonged OS PFS with avelumab plus bezaboticab versus bezaboticab alone, irrespective of PD-L1. OS at 2 years was 49.8% in avelumab plus bezaboticab versus 38.4% in bezaboticab alone. The 2-year PFS rates were 23.4% versus 7.1% respectively. The long-term safety profile of avelumab was consistent with the previous monotherapy studies, and no new safety signals were identified. Overall survival was prolonged with avelumab first-line maintenance despite a high proportion of patients treated with bezaboticab alone receiving a subsequent anti-cancer drug therapy. And the results further support the recommendation of avelumab first-line maintenance as a standard of care for patients with advanced urothelial cancer that have not progressed with first-line platinum-based containing treatment. And long-term safety data with high percent of patients on treatment at 2 years indicate a good tolerability, durability, feasibility of the regimen as treatment until progression. So by and large, we are having consensus here that platinum eligible, go for platinum-based doublet. Gemcitabine, go for avelumab maintenance. Platinum ineligible, carboplatin-based doublet, go for avelumab maintenance. Platinum ineligible, go for IO monotherapy. I think there is no doubt as of now. So Bavencio is available in 800 milligram IV infusion. Over 60 minutes you have to give every 2 weeks, which is much better tolerated. And pre-medication and adjustment to the infusion rates can help to manage infusion-related reactions. Pre-medicate with antihistaminics with paracetamol prior to the first 4 infusion of Bavencio. This is very, very important. This is what I want to convey. So thank you very much for your inputs. I want to say thanks to Dr. Piyush, Dr. Vikas Talreja, and Dr. Abhishek for giving their valuable inputs. And may I ask the organizer, that Merck, Pfizer team, to throw light upon the pharmacoeconomics of this drug. So back to Love.
Yeah, hi, sir. First of all, sir, thank you so much for the comprehensive presentation and taking us through the entire data. Thank you all the panelists, Dr. Piyush, Dr. Vikas, Dr. Abhishek, for putting your perspective on the table and making the discussion quite interactive. Sir, as far as the cost of the drug is concerned, the MRP of Bavencio 200 mg is 1,46,000. And to the patient, it will cost around 1,22,000. And it comes with a patient assistance program of 1+2. It means if the patient purchases 1 vial, then 2 vial will be free from the company side.
Can you speak it once again? What is the vial strength of avelumab, Love?
Sir, it is 200 mg.
200 mg. So dose is 800 milligram, right? So what is the cost of first 800 milligram by MRP first, and then with patient access program?
Okay, sir. Sir, by MRP, it will come to around 5,84,000.
Okay.
And
patient access program is 1+1, right?
1+2, sir.
1+2, fair enough. So
Yeah,
how much it will come down? Like if we enroll all the patients in
So,
patient
sir,
access program?
for first cycle, it will cost to the patient around 2,44,000.
2,44,000.
Yeah.
Right, fair enough. And first response assessment is after 4 cycles. So we have to give twice, like patient have to pay twice, right? To avail the patient's program, right? So
Yes,
how
sir.
much is the cost of 4 cycles if we are enrolling the patient in patient access program? Can you be specific in this answer? Dr. Love, are you there?
Yeah, sir. It will come to around, sir, 14,000. 14 lakhs, sorry.
14 lakhs for
Yeah.
4 cycles, right? And this
yeah.
is the cost only of immunotherapy.
Yeah, yes.
Right. After patient access program also, this is same only, right?
Yeah.
Fair enough. And the cost of chemotherapy plus immunotherapy will be even more.
Yeah, yes, sir.
And the PET scan report. Right. Fair enough. So by and large, it is around 115 lakhs by which patient can afford
yes,
it.
sir.
By and large, if you can say, right? So when we are using avelumab, we have to tell the patient and responsibility nets that it is going to cost nearly 15 lakh rupees, whether you are take it or leave it. It's something like that because it's having oral survival benefit or probation-free survival benefit. So treatment cannot be considered as treatment until it is affordable and accessible. So we have to select the right fit patients, and we can give the maximum advantage to the patients. And this is a viable option, especially for ECHS, CGS, or panel patients in which affordability is not an issue. And those patients who are out-of-pocket patients also, we have to very carefully select, and we have to spend a lot of time in counseling these days because of the pharmaconomics knowledge which is required for decision making, right? So I think the message is very loud and clear, and thank you very much for being part of this scientific session. Thank you very much, Piyush sir. Thank you, Dr. Abhishek and Dr. Vikas Talreja. Good night. Bye-bye. Take care.
Thank you, sir. Thank you, all the panelists and all the attendees.